All right, welcome back to another podcast. Got, of course, Dr. Jason Williams here joining us. Always love these conversations. Dr. Williams, welcome to 2025.
Yeah, thank you, Nathan.
Good so we're a year younger, aren't we?
We're now now with our new stuff, we're working on aging in reverse, so we'll see.
That's what I was kind of alluding to. We'll get the body younger. So, and actually on a note there, I need to pull up that study and send it to you. There was a study that came out that was actually talking about the future of oncology therapy is going to be in regeneration.
Yeah. And that's of course a lot of even the stuff that we're trying to do now with some of these cancers is, like sort of reprogram the cells and try to like get them to behave more. So that's a lot of stuff, when we're injecting some of these things into the tumors, that's kind of a little bit what we're doing.
Yeah, and I think that's a good tie into what we're about to talk about, because the way people have approached cancer treatment for the last 100 plus years or so, it's basically going to war on the body. It's chemo, radiation, surgery, targeted meds, systemic immunotherapy. And really what you and the Williams Cancer Institute, what we're doing together has done is brought forward, I think, the pivot point in history for cancer care, which is, hey, let's innovate. And the innovation here is really by empowering the immune system by going to the tumor, and now, we're doing other things, working in regeneration, which is super exciting. So there's not really any place better to be than the Williams Cancer Institute if you want to see the future of cancer care today.
Right. Yeah. No, I mean, obviously we have all the weapons. So,
it's the delivery technique. But exactly. Here we're talking about, I want to talk about ivermectin.
Yeah.
Every now and then I get on social media in the evening and I look and see what people are talking about. And I really like to look at the dialogues between doctors and patients. And it's really interesting because I think in many ways it shows the disconnect right now that doctors and patients have. Yeah. And I don't know if you're aware, Jason, there's this earlier in the fall New England Journal of Medicine article looking at the trust of patients in doctors and hospitals is really at an all-time low.
Yeah.
40%. And it's truly startling. But looking at the dialogue between the doctors and patients, and I saw one last night, they were talking about ivermectin. Yeah. And I can see why patients don't have a trust in doctors, because the doctor was not speaking to them. He was speaking down to them.
Yeah.
And he was voicing information that was not accurate.
Right.
So you have experience with ivermectin. I have experience with ivermectin, but I think with patients, they're going to find that the innovation that you've applied to everything at the Williams Cancer Institute, it applies to ivermectin also.
Yeah.
And it really shows that, we're not just taking something that's arbitrarily out there. We're applying the science to deliver it in the best way.
Yeah. Yeah. Ivermectin, I would say it's kind of coincidental. It started getting, interest in cancer and COVID sort of simultaneously, right? Seemed like those two things were hitting both at the same time. So then you try to look at what's the similarities there between that, and what does ivermectin do that would be beneficial both in cancer and then also technically in COVID. So you obviously look at the immune response and what ivermectin does. Now, some of the studies show that ivermectin in cancer cells seems to cause an immunogenic cell death, leading to, release of various things like what we call high mobility group box homolog, things like that, various signals to the immune system that maybe this should be attacked. And so that's certainly on the positive side. You look at, what's its effect on the immune cell population, seems to boost, CD4, CD8, does it, then the question is, then are there the right type of cells, right? Are you boosting, cancer attacking cells? Are you boosting regulatory cells? Because in some situations, these things are not, the exact target. And ivermectin does seem to be, favorable that, it's decreasing sort of the regulatory cells. And so there's a, real interest there several different mechanisms. I mean, this like, PX247 thing is, I don't know if you've seen all these different pathways and stuff that got, but yeah, so lot of interesting results there, and so it seems that ivermectin may kill cancer to some degree, and then also may do it in a way that stimulates an immune response. Now, when we look at chemotherapies, some chemotherapies do this, as well, but also some chemotherapies have the issues of knocking down a lot of your immune cells simultaneously, and it seems like ivermectin is not as bad for that, right? It doesn't seem like it's really affecting the or suppressing the immune system. Again, they're also looking at different ways. You gotta look at like the dosing. I mean, some of the studies that I saw, the dosing is completely different than what anybody would take normally, and also most of the dosing is pulsed, doing these 3 days on, 5 days off. Because you look at the half-life of ivermectin and you look at how it works, that tends to be the way that you would do it, where it's like a 3 day on, 5 day off type cycle, and dosings of 30, 45, and 60 milligrams, or what we're seeing, which is of course way different than what you would normally see with typical ivermectin treatment, say for parasitic infection or something.
And what you're really highlighting there is the specific detail in that we're not making proclaims, right? So proclamation is a claim. It's just it's naming something, it's describing it, it's announcing it to the world. And so last night, again, on X, formerly known as Twitter, there was a proclamation that was being made by an ER doc in terms of taking care of a patient. And he was, making some claims that were inaccurate. So what we're doing here, and what Dr. Williams is describing, is just simply that the evidence is leading the way. And so when you check out the show notes, you'll be able to see all the evidence supporting this. And we want you to read it for yourself, because some of this may be deep dives and deep details, but understand it's important because we're following the science at Williams Cancer Institute. The science leads the way, but it leads the innovation. And then that's the super exciting, because that's what will bring forth the coming treatments that we bring. Now, you bring up a really interesting point in that, people look at these repurposed medications. And I think one of the problems we have, Jason, is that your conventional doc doesn't engage with the patient. Mm-hmm. And they don't know much about these repurposed medications. Of course, ivermectin got vilified during the pandemic. And so because of that, I think it really made it more famous.
Yeah.
I mean, there's 4-letter words, and then there's ivermectin, right? I mean, it's going to catch people's attention, and it really puts them on different ideological sides. But, the anti-cancer mechanisms, both in vivo and in vitro from ivermectin, are well described. They inhibit proliferation. They're chemosensitizers, so improving the sensitization. They induce apoptosis. They modulate the tumor microenvironment. They're anti-angiogenic. They inhibit DNA repair, inhibit cancer stem cells. But obviously, what we do at the Williams Cancer Institute, and what you pioneered and continue to pioneer, is its impact on the immune system. And I would garner that most people that are taking ivermectin for cancer, most doctors that are prescribing ivermectin for cancer, Jason, they don't think about its immunomodulatory impact.
Right. Yeah. It's definitely an interesting drug. We've worked with it on off. Obviously, one advantage of our clinic in Mexico is that we have injectable ivermectin. So and clearly, all these things are things that you want to inject into tumors and see what happens. And so, if you get these results giving it systemically, then what do you get when you put it in the tumor? And so by having an injectable form, is a nice way to look at that. And then, then you start looking at combination, injecting ivermectin, injecting vitamin C, injecting, all these other immunotherapy agents. Obviously, the more and more things that you inject in the tumor, and you change that tumor microenvironment. And so, this is obviously the work that we're doing. And ivermectin is definitely an interesting additional weapon to have that, it's cost effective, because, a lot of our immunotherapies are super expensive. I mean, these, if you use cytokines or if you're using monoclonals, these things are very, very expensive. Whereas if you can achieve some results with some small molecules, you can help get, good benefit with cost savings. So that's a nice added benefit there.
And the precedents already exist when you look at systemic immunotherapy. When you look across all cancer types, the immune response, the response rate, and that's just any response that's positive, is somewhere around 15-25%, depending on the cancer type. There's a very large meta-analysis that is about 15.68%. And so people go, wow, immunotherapy, it is so exciting, so cutting edge, and it's true, but yet its systemic to tumor approach is really minimal.
Yeah.
So what you pioneered then also was saying, well, let me take that and bring it to the tumor.
Exactly.
And so we really bypass a lot of the limitations of that systemic approach, right?
Yeah. I think anybody, obviously if you're looking like standard of care, patient's going to get like, Keytruda, Opdivo, some, systemic PD-1. I mean, you really, to make that work better, you need to be trying to hit the tumor with some other things. It could be, as simple as, ivermectin, vitamin C, flu vaccines. I mean, all sorts of stuff. You can inject all sorts of things in the tumor to try to make that work better. That's going to work better than just giving the immunotherapy alone. So there's lots of ways that you can enhance this. Giving systemic immunotherapy by itself without injecting the tumor doesn't really make any sense.
Well, and that's what you showed by going to the tumor with the immunotherapy. So you proved the concept there that the right approach is taking something that activates the immune system, whether that be a conventional immunotherapeutic or not, go to the tumor. So it stands to reason that ivermectin is going to follow a very similar pattern that immunotherapy does. And if it's working within the immune system, which, again, research is really pointing that way. And again, we have to recognize and talk about that the research here we're talking about is in vitro, in vivo, predominantly animal models at this point, but hopefully, this will be coming to humans very soon. But there's one article I'd really like to highlight because I think it really kind of encompasses fully this connection about ivermectin in the immune system. And it's an animal model looking at breast cancer. It's entitled "Ivermectin Converts Cold Tumors Hot and Synergizes with Immune Checkpoint Blockade for Treatment of Breast Cancer." So, of course, this was all via the classic strategy set up that the standard of care operates under. But, this study shows the power of the two together. But what you pioneered and what we're doing to Williams Cancer is we're bringing those together into the tumor.
Yeah.
Which I think changes everything. Everything.
Yeah, I mean, you need to put it right at the source. I mean, you want the immune system to attack where the cancer's at, and when you're sending the signals everywhere in the body, you're sending mixed signals, right? Because you're telling the immune system to attack in places that there's not cancer. What you want to focus on is hey, attack here where there's cancer. That's what makes sense. I mean, I don't understand why, you got to go after the tumor.
Well, let me ask you a couple questions here. What's a cold and hot tumor? What does that mean? And do you think does a cancer and in the tumor microenvironment, does it create kind of a barrier, a buffer that makes it harder for systemic therapy to get into the tumor?
Definitely. And some tumors are so stealthy, they grow and they look like they're so much part of the body. The immune system doesn't see it. Nothing sees it. There's nothing trying to attack it. It's just completely, they're growing, but taking up its space or spreading, and the immune system not bothering at all. That's a complete, immune desert. I mean, there's so what you need to do is try to alert the immune system and say, hey, this stuff is not normal. This shouldn't be growing. So you got to give it those signals, and that's various things. And ivermectin can help. There's other innate immune signals that you would do to try to recruit those immune cells into the environment. You got to get the immune cells that they're looking at it first. If you give PD-1 inhibitors and stuff like that, that's all T cell, that's late. That's not going to do anything if the immune system's not seeing it. So you first have to really prime the immune system to see the cancer and to want to attack it. And then those other drugs like the PD-1s can be effective. And that's why they see such low, results with those, because most cancers are not being infiltrated by immune cells. And so until you get that going, those PD-1s are useless.
and you basically get it going by
Yeah.
bypassing the limitation and just going right into the tumor.
Exactly. Yeah.
Yeah. And again, we've talked about why more people don't look at that as the way. And I think more people are. I mean, you're
Yeah.
starting to see a lot more interest in it. And, but once you innovate, I don't think you ever turn that innovation light switch off, do you?
Yeah. Yeah. I mean, there's so many things you can inject in tumors. It's just a matter of like, what are the right combinations to get in there to get the immune system really seeing it. And so that's what you have to do, with the patients, is you hit them with various drugs and you keep putting those in the tumor and you try to get the immune cells, seeing the cancer. Then once you start getting the immune cells seeing the cancer, then you can push it more. And so, yeah, that's kind of the whole process to treat it.
So cold tumor is a tumor that's not immunoresponsive, right? And a hot
Right.
tumor is a tumor that now becomes immunoresponsive. So basically the title of this article in this animal study, it's saying that they're taking a non-immune responsive tumor, breast cancer model, and they're converting it now to one that the immune system will actually activate against the tumor.
Yeah.
Now, it's really interesting when you look at the results of the study. 40% of the animals were, the best survival outcome was in those that received the combination of the immune checkpoint inhibitor with ivermectin, and that 75% of the animals were long-term survivals in that group. And there's actually a beautiful graph there, and you'll see this in the show notes, where they did 4 groups. They did no treatment. They did ivermectin alone. They did the anti-PD-1, and then they did the ivermectin and the anti-PD-1. Now, what's interesting is in the mouse model, the ivermectin outperformed the anti-PD-1 alone.
Yeah. Wow. Yeah.
But it was the combination together
Yeah. Sure.
that blew everything away in terms of reducing tumor burden and tumor volume versus each alone.
Yeah. 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 You got to get these tumors heated up first. That's a key. And so,
And by heating up, you mean you're activating the immune system?
Yeah, exactly. Yeah. And so, from our standpoint, the best way to do it, is putting a needle in tumor, doing pulse field ablation, injecting some drugs to attract the immune system, getting that going, getting the immune system kind of seeing it. And it's a process of, and it depends on the cancer. Sometimes it's quick. Sometimes the immune system jumps on top of it. Sometimes the immune system's sluggish. And you got to keep pushing and pushing. Depends on the cancer.
Yeah, you bring up an interesting point. You talked about put a needle in it. I think there was a song on that. But you put a ring on it. But put a needle in it. Yeah, got that wrong. But putting a needle in it, a lot of questions I get, and I'd love to hear your take on this because I think patients would love to hear that, is, okay, well, I've heard about the risk of, biopsy, local reseeding, tract reseeding, and spread of cancer. If you put a needle in a tumor, it's there of the cancer spreading, if that's causing that issue.
Well, your risk are when you put needles in and you're not doing anything, which is like biopsying and other interventions where they access a tumor, but they're actually not doing any therapeutics. Whereas if you're accessing a tumor and you're doing therapeutic to it, then you're sort of mitigating that, right? You're getting the immune system to try to attack it, so your risk would be actually reduced on that.
Yeah. So basically, what you pioneer, what we do that's so unique is it's getting to the tumor, accessing the tumor, but it's for treatment. It's not just for tissue sampling. Though we can do that, we treat.
Yeah. Yeah, you really shouldn't be sticking a needle in a tumor without doing some sort of treatment. Otherwise, you're really making a big mistake.
Another interesting thing about this study is that they were using this as a neoadjuvant treatment, and they still did surgical resection of the mice.
Yeah.
So it's showing that we can use these kind of integrative strategies, the innovative approach, immune system, but still using this in some of, if somebody needs surgery, to provide a better result. So it's not like we're going out there and saying, hey, we're all you need, you don't need your oncologist. We're saying, no. What we're doing is pioneering to make therapies across all treatment strategies better, safe, evidence-based.
Yeah, I mean, we can. The thing is that what we do, we can jump on top with any other therapy. Let's say a patient is newly diagnosed and they're saying, we're going to put you on, let's say they're colorectal cancer, and then put them on, FOLFOX, FOLFIRI, some sort of chemotherapy. At that point, we can jump in, we can start ablating, injecting, and they can still do their chemo. They can still do their stuff if they want to do it, and we'll just make it work better. We'll make the immune system want to attack it, and we'll combine with other therapies. Any other therapy we can combine with. I mean, certainly there's certain situations maybe the standard therapy might impede what we're trying to do, but a lot of times, I mean, if the patients are like unsure, and say, well, because everybody thinks, oh, it's this therapy, it's that, it's like but no, we can throw everything at it, jump right on top of it, and give it everything. So you can do what you're doing with your current doctor and do the stuff with us at the same time.
Well, I think it's a brilliant point you put there, is that it's not, you can't just look at cancer in a sequential step-by-step process.
Yeah.
If we do that, we're thinking basically in just a monolithic way, but cancer is almost kind of acting then in a quantum physics way. And so we need to think more like cancer, and the stacking of therapies, the integration of these therapies all together. And that's really, people think, well, you're injecting one thing into the tumor. You're doing one thing, and that's really not the case.
No, we're doing many, many things. And so, yeah, I mean, the thing is that, if a person's getting treatment, we can make it better. It's like standard of care plus, right? So they get the standard of care, and we jump on top of it and make it better.
Yeah, and that's what I love about this approach, the integrative approach, is because when you look at the different factions in medicine, you have conventional, you have holistic, you have natural, and nobody wants to work together. But yeah. I really think what you pioneered, again, about a decade, if not longer ago, and now what Williams Cancer, that I'm thrilled to be a part of as we move forward, I think we're building bridges. Yeah. And I think that's going to, first of all, I think what it's going to do, it's going to help patients.
Yeah.
You have said this over and over again. You do this because you want to help people.
Right.
I mean, and I think that says something about you as a person, that the goal here is to help patients, to help them live longer and high quality of life.
Yeah. Yeah. We want to be able to treat this disease, and we want to be able to do it in a way that's very acceptable to the patients. We want them to, we want to try to get rid of their cancer. We want to try to do it in a way that they don't have to really suffer through significant difficulties in treatment, make it as easy as possible.